Hi, I'm Dr. Tim Babineau. I'm the Chief Physician Advisor at ECG Management Consultants, and I would really like to welcome you to the first of 3 podcasts entitled White Coats in the Corner Office, where we will explore the journey, the role, and the perspective of physician chief executives, a role that I had the privilege of holding for nearly 15 years before I joined ECG. I am delighted to be joined by not only 2 colleagues, but 2 people I call friends this morning. Dr. Joanne Conroy, President and Chief Executive Officer of Dartmouth Health, and Dr. Eric Dickson, President and CEO of UMass Memorial Health. Dr. Conroy, Dr. Dickson, welcome.
Thank you, Tim.
We have a short time, so I'm going to dive right in here. And I'm going to start with you, Dr. Conroy. If you wouldn't mind, just let the audience know a brief overview of Dartmouth Health System, and then a brief overview of your journey from clinician to the corner office. Dr. Conroy?
Sure. Thanks, Tim. So Dartmouth Health is one of the most rural academic medical centers in the country. That's defined by how many people we have within 30 miles of the institution, which is about 160,000. Our organization actually is the largest provider of care in New Hampshire and very close to being the largest, or neck and neck with UVM in Vermont. We have an academic medical center, and we have 4 critical access hospitals, soon to be another one. And then we have 2 PPS hospitals in the southern part of Vermont and New Hampshire. And we have a visiting nurse and hospice association. So we serve about 1.6 million people and are trying to be really, really good at rural health care and be really, really good at taking care of older people, because we like to say we're old and cold up here. We have one of the oldest populations per state in the country, and between Vermont, New Hampshire, and Maine. And so we should be really, really good at delivering care to these individuals. My journey to the corner office probably began at the Medical University of South Carolina. And, there was a situation where first my department and then the university hit some financial troubles. First was probably from kind of management infrastructure, but the university was with the Balanced Budget Act in 1998. And I stepped into leadership at that role because they needed a clinician to be part of the 3 individuals that were going to close a huge budget gap that everybody experienced in the US in 1999. And, it's interesting that I loved anesthesia, and I'm an anesthesiologist. Sometimes I tell people my voice is like 5 milligrams of Valium, and it is. And but I really loved kind of solving problems, and they were really complicated problems. And it used a different part of my skill set, and I realized that I actually enjoyed it. First, becoming chair of the department, then senior associate dean, and VPMA of the medical center all at the same time during the recovery. And then I went to Atlantic Health, where I became a CMO and EVP and then president of their flagship hospital. And then to the AAMC, where I got to really understand policy and help develop a lot of it during my time there. And then back to Leahy, and then finally to Dartmouth Health. What's interesting is I did begin my education at Dartmouth. I was a 1977 graduate of the college. And I never thought I would go back there, but there's something kind of fulfilling to be kind of closing that loop on the communities that you want to have an impact on.
Awesome. Thank you so much. Dr. Dickson?
Tim, thanks for having me, and especially with Joanne on. I've always been a big fan of hers. So my career in medicine started right out of high school when I joined the Army to be a helicopter pilot, and it turned out I didn't fit particularly well in a helicopter. So the Army said, you have to choose something else. We're not going to let you out. You're in. Once you're in, you're in. And I became a combat medic in an infantry unit, which was still one of the best jobs I've ever had. And so there I was, 18, 19 years old, carrying a giant sack full of medical supplies that I didn't really know how to use, and they call you doc. And I kind of fell in love with it. And so the Army trained me as a medic and then as a respiratory therapist. And then when I came out, I decided that I wanted to continue my education and truly become a doc. Went to UMass Med School, UMass for residency in emergency medicine. My first doctor's job was at UMass Medical, in the UMass Medical Group, in the faculty position, and was doing mostly research. And a funny thing happened right around the time I was coming out of residency. The state said they didn't want to own a hospital in a medical group, so they took UMass Medical Group and UMass Medical Center and said, you're going to go merge with Memorial Medical Center and Memorial Medical Group. And that created UMass Memorial. And I hated it. I thought it was the worst idea in the world. Many of my fellow faculty members fought it and pushed back on it. And here I am, 25, 30 years later, running it, the thing that I never wanted created. But UMass Memorial has done a lot since those founding days. We've got 11 hospital campuses now, what used to be 11 separate hospitals. We've merged them into 5 licenses so we can easily move patients between them. We're up to 21,000 caregivers, $5 billion in expenses. Unfortunately, not $5 billion in revenue this year. I'd like to say have it be the other way around, but really we are the, I guess, most rural academic medical center in Massachusetts, because the other 5 are in Boston, and we are the only one outside of Boston, and we are tightly affiliated with the state's only public medical school. And I never wanted to be an administrator. I always wanted to be a researcher, and somehow you get pulled in. But in the end, I've loved doing this job because it's in many ways allowed me to make a bigger difference than I could make either doing research or doing clinical care. And thankfully, I get to still do a little bit of both on top of my administrative duties.
Dickson, thank you. I can remember vividly when I told my father, who Eric knows well, who is kind of the Norman Rockwell town doctor of Fitchburg, that I was leaving my surgical practice of 25 years and was going into administration, to which my dad, responded, so you're going to the dark side. And I said, well, Dad, you can curse the darkness or you can light a candle. And hopefully I would light a candle. I personally believe physicians bring a very unique perspective to the corner office. Let me be very clear. There are spectacular CEOs in this country that are not physicians. I'm not suggesting if you're not a physician CEO, you're not good. Joanne, Eric, our friends, our colleagues, they're brilliant. But I do believe having the clinical background brings a unique perspective to the role of the CEO. When I was a physician CEO, I woke up every morning as a doctor and then walked into the office as a CEO. I'd love your thoughts, your perspective on how you think about that. And Eric, we'll start with you.
I think it's very helpful to have the medical background to understand some of the complicated aspects of clinical care that would, are really hard for your MBA type. I think the danger in it is that you focus too much on the medical components of it and you forget that you're the chief administrative officer for the healthcare system. So I've seen some absolutely terrific physician executives that are CEOs of healthcare systems, and I've seen physician executives that have messed it up because they didn't balance between the two. So my mentor was not a physician, John O'Brien, who was the CEO of the system before me. And I don't think it in any way is necessary, but I find that it helps me a lot. If you don't have a medical background, you better have a real good CMO, I like to say to other folks that are in this role.
You know what? I would add to Eric's comments by saying, there are some conversations that some of our non-physician colleagues don't really want to weigh in on, especially if it's a kind of a quality cost conversation. And with a medical background, I have a pretty good sense of when somebody is overstating an issue, either on the quality side or the financial side, but specifically on the quality side. And sometimes people can be passionate about making a case for something, but as a provider, you kind of know when that's probably overstated. And so that does help you kind of find that path between quality and cost, which is kind of the value journey that I think we're all on. I think the second thing is we do have a perspective of what physicians want to see or hear in order to be supportive of the health system. I'm a big fan of transparency. I think a lot of our physicians are incredibly bright, and many are really interested in the administrative component of how we deliver care. But I also appreciate the fact that some data that our administrative teams find incredibly fascinating doesn't really get to the heart of the matter that's going to drive physician behavior. And so I think that's helpful. It's almost like we become translators between two worlds. But there's such important partners to have that we need to do everything we can to really make sure that they can be effective partners.
Great. Thank you. I have mid-career physicians not infrequently call me and say, hey, looks like you had a pretty cool job. How do I get that job? And I have some very specific advice, which is stay at the bedside for a little while longer. If you were going to give, a mid-career physician, let's say they've got 20 years experience, who, thinks they want to do more, do they need an MBA? Do they need to go to business school? Do they need to get more administrative responsibility? If you were mentoring a very bright, let's call it early 40s physician who admires the two of you, who would like to take over your jobs when you retire 10 years from now, what advice would you give them, Joanne?
So I do mentor a lot of people, and I would say it depends on where they are in their career. So if they're younger and have both the freedom and the resources to get an advanced degree, I think that's a great idea. Sometimes I have people come to me that are 45 or early 50s, and I have to say you have to weigh the advantages of getting that versus really demonstrating leadership and getting the right experience. But you're right, Tim, it's all about how do they move into leadership roles where they actually can have a manageable portfolio that's measured usually in FTEs and budget. And how do they then stepwise increase that level of responsibility and oversight? So when they go to apply for a job, they've already got some of the basics under their belt, and they can actually be considered.
I like to focus on three things. I usually say first and foremost, if you want to be able to, we'll call it moving up. I don't know that it's really moving up sometimes, some days. You have to treat everyone with respect, kindness, lead with love. That if you are going to apply for a job, especially within your own organization, and everybody thinks you're a jerk, you're not going to get it. No matter what you've delivered, especially in 2025. And so just, and it's hard to teach that, right? But that is it. Second, you have to deliver results, as people have to see you delivering results on behalf typically of your boss, results that they want to see. So treat people with respect, deliver results for your boss. And the third thing is volunteer. Every opportunity I ever got was because I said, I've got some extra time. I'd be happy to step in and be chief operating officer for the hospital for a while. You don't have to pay me extra. I went and got this degree. I got a master's in healthcare management over through the Harvard School of Public Health, and that is, people are looking for, especially physician executives that are willing to give you their time to help solve complicated problems. And so those three things, and often people aren't willing to put themselves out there and say, I'm willing to do this. You don't have to give me a stipend or anything, but that's the thing that gets you in the door.
I couldn't agree more. I'll tell you just a quick anecdote. There's a famous hospital in Boston. I won't name it, but it lives at 55 Fruit Street. And, 30 years ago, there was an aspiring physician executive who, wanted to advance in his career. And I never forgot this story. I won't mention him by name, but he went to the CEO of the hospital, and he was a very seasoned clinician, the go-to doc for the VIPs in Boston. And he said, "What's the most broken department in the hospital?" And the CEO said, "Laundry." And he said, "All right, give me laundry, I'll fix it." And he got it for free, and he fixed it. And that was the catapult of a very storied career. I think you know who I'm talking about. So I never forgot that story. All right, this has been great. Now we're going to get into a little bit of harder questions. One of the reasons we're doing these podcasts is ECG, and I personally believe, and again, privileged to count you as friends and colleagues, is in my 40 years in healthcare and your 40 years in healthcare, I can't remember a more challenging time. I mean, I really can't. It just, around every corner is a boogeyman. There are no easy answers. The low-hanging fruit is gone. And that's why I personally believe the physician and executive experience matters now more than ever. Softball question, haha. What's wrong with American healthcare and how do we fix it? Joanne?
Our incentives are totally at cross purposes. If we could have an alignment among providers and payers, and I regard the federal government kind of as a payer as well, we could make huge progress in delivering greater value. But, I think about the decisions we make as a country. For example, people want to be cared for at home. They don't want to stay in hospitals. And yet we undervalue and underinvest in home care, or, the mayhem we're facing with hospital at home programs right now. When we seem to do something really well, then we do something to undermine it. It just doesn't make sense. I think in many areas of the country, there are barriers for physicians and hospitals actually working together. And that just is misaligned incentives. The incentives around fee for service were totally misaligned, but we develop all of these kind of payment reform programs, but within each of those programs is a fee-for-service infrastructure. It's a fee-for-service machine and a reconciliation process that you have to run at the same time. It just kind of doesn't make sense. And if I could do one thing, I would align all of those incentives. Just imagine if you actually had your major insurer as your partner trying to work with you, how much of our sunk costs we could get rid of, how much better care we would give, and how much less it would cost.
Thank you. Eric?
First, I just have to agree with Joanne. I'm wearing my hospital at home shirt today. Program I had to close yesterday because of the federal government shutdown. My home-based programs, our home-based programs, especially mobile integrated health with calls I take still, unbelievably how efficient, high quality, saves on ER visits, and we get paid nothing for them. And with just total misalignment with the payers and the providers. What But I usually talk about, I have a list of 10 things when I give my lecture on what we need to do. But I've had to boil it down for the legislature to like one thing. And I say, today, what we need to do today is take the massive administrative burden that is on the back of our primary care providers away so that they can see patients, because we have inadequate primary care access, and we're seeing people, the real overuse that you see in healthcare in the United States is primary care sensitive illnesses that end up in the emergency department seeing me for much more expensive, less efficient care, all of which could have been dealt with days earlier in the primary care clinic, but they couldn't get in. And so if we can take the administrative burden off the backs of the primary care docs, we'll have more primary care capacity. We'll lower the cost because we spend about 25% of the overall premium dollar on administration in the US. It's 6% around the rest of the world. So that's where I would focus my attention. That's what I'm trying. Anybody that will listen, that's where what I'm saying. But that's not what we're doing, unfortunately. And we're seeing things deteriorate: access, ER wait times, and with no clear plan about how we're going to change it.
Eric, thank you. We're going to close this out. I'm going to reference a dear friend. I think both of you know Jack Connors, who was the seminal chairman of Partners Healthcare, dear friend, mentor to me. Unfortunately passed away, as you know, several months ago. Jack and I would grab lunch together at Davio's every 6 months and have a lemonade, and we got the same pasta dish every time. But Jack was an icon, as you know. And he had a famous line that he would mention in the last 10 years when we would meet. And I plagiarize it all the time, but I give him credit. And Jack would say, I got nothing left to prove, but I got a lot more to give. And one of the reasons I'm doing this is because after 40 years, I got nothing to prove, but I feel like I have a lot more to give, because American healthcare is so important. What would be your closing message? What would you like to give to the people listening to this podcast? Because it is the foundation of our country, American healthcare, and it is in such a mess right now. Joanne?
You know what? I do tell all of our teams that there are things that we can control and things we can't control. And the things we can control is the compassion, the investment in quality outcomes, and the connection with our patients and our colleagues that we work with every day. We are woven into our communities, and we can control that. And I have our staff and our teams actually focus on what they can control, and let us deal with the mayhem outside so they can just focus on doing their jobs, which they do amazingly well every single day.
And thank you. Eric?
Yeah, I miss Jack too, Tim. He was just a special person. His picture's hanging in my office if you ever come by. And I think, your comment sums it up. And that what I would say to people is just don't lose sight of the fact that there's a patient in front of you that needs your help. And all of the mayhem, we'll do the best we can with what we have to work with, but it's about the patients. And when you really feel bad about yourself and you're having a hard day, go to the front door with a wheelchair, wait for the person that needs help getting out of the car, wheel them to their appointment, and talk to them about what's going on in their life. And suddenly your problems aren't going to seem too bad. And I started the conversation today with Joanne, thanking her for going to see a friend of mine. And that part of, every chance you get, go down to talk to a patient, whatever problems you're having won't seem so bad, is absolutely true. And so appreciate you doing that, Joanne. And Tim, I know your dad and your brother really well. They'd be proud of you. Your dad be proud of you, right?
All right. You guys are extraordinary. I could do this for another couple hours just because I love you as friends, but I know how busy you are. Thank you so much for your time. I will tell you have set the bar extremely high for the two podcasts that follow. I will open the other two with, man, you should see what these guys said. So you knocked it out of the park. Can't thank you enough for giving us and the audience a half an hour of your time. I wish you good health, and I hope to see you in person soon.
Be well.
Thank you. Nice to see you, Eric.